Hello, everyone. Here is Joana Pestana. I'm based in Nova School of Business and Economics in Lisbon. I'm going to show my results from a research, a joint work with my supervisor, Professor Pedro Pita Barros. So this paper focuses on the measurement of technical efficiency in the primary care unit practices in providing care to patients with chronic conditions, pregnant women, and child care. So this is important because wasteful spending on health has been a concern shared by several OECD countries. There are several policy instruments to address this issue, which have been used in the outpatient sector, including changes in payments and financial incentives, as well as changes in the organization of the practices, which include, for instance, the creation of multidisciplinary teams, and these are advocated to improve access, quality, and cost efficiency, though the empirical evidence to support these claims is still scarce. In this paper, our objective is to assess the technical efficiency and cost containment of the outpatient sector. For that, we use cost and production data at the practice level, and we focus at variables that are factors distinguishing between the different organizational models and the efficiency of these models. What we want to identify is where there are different economies of scale in all the different models which are resulting from the reform in Portugal. In this assessment, we include relevant variables that account for the heterogeneity of the population served or the environment where the practice operates. We try as much as possible to include activity-oriented as well as a quality-oriented approach. So let me give you a short context. We are looking here at two different organizational models that coexist since the reform of 2006. This reform in the primary care in Portugal gave the physicians the possibility of creating their multidisciplinary teams in which they would have more technical and functional autonomy and larger patient lists. If these teams could meet the quality targets, they will be entitled to receive a team bonus to spend in training, material, and renovations. Plus, if they keep having good quality indicators, they'll have the possibility to migrate into a more advanced organizational model, the Model B, in which they would receive individual monetary incentives and tighter performance targets. The initial plan was to migrate all practice to team-based models, but after 15 years of the beginning of the reform, we still have more than 1/3 of the workforce still working in non-team-based models. So in order to assess the differences between these models, we use administrative data from 2016 to 18, and we assume that the costs are driven by a short-run cost minimization function using the total cost of the unit, which is the salaries, includes salaries, subsidies, and incentives, as well as healthcare costs, which are physician-induced, such as prescription drugs and diagnostic tests. The outputs, we have different specifications, so we use the classical definition of output for the primary care, which is the number of visits per GP and nurse, but also we include 3 intermediate outcome measures that are obtained through the combination of quality indicators, and this measure the adequate care of patients with diabetes. We use the adequate care of patients of pregnant women and of children under the age of 2. To estimate the cost function, we use a stochastic frontier cost model for panel data that specifies the best practice through maximum likelihood estimation. We also separate the error term into the statistical noise, which we assume to be normally distributed, and the inefficiency term, which we assume to be time-varied and following a truncated normal distribution. We include the vector X or environmental factors in the estimation and 2 dummy variables which indicate the type of model that the unit follows currently. In doing so, we are estimating 3 separate cost frontiers, imposing this common error structure in all of them. Let me show you the results. Here using the Cobb-Douglas function, and I show you 2 models. The model, baseline model with only the volume of visits, and the other second model showing both visits and quality indicators in the same production function, cost function, sorry. So regarding the coefficients, nothing new in the cost elasticity of price of resources. So if wage increases, costs will increase. Now, if you look at the responsiveness of the total cost to changes in output, this varies according to the output. So it is positive on volume, which suggests that the cost output elasticity regarding changes in the volume of production will probably be high. And this indicates that there are unexploited economies of scale in the production of office visits. However, if we look at the model 2, this coefficient is negative for quality. This means that we cannot expect any savings coming from the spreading of costs over higher qualitative achievement levels. The figure on size is also interesting, list size, which is given by the ratio between number of patients per GP. Here, the coefficient indicates that the increase in costs from more patients will be lower than the increase in patients per GP. And this again suggests that we have economies of scale in the list size of the units. The other factors that contribute positively to the cost of the units are, as you would expect, the complexity index, the more socioeconomic, the more disadvantaged socioeconomic conditions and the number of chronic conditions will increase the cost, as well as the higher number of the portion of patients living in urban areas would also lead to more costs. The time trends, they indicated that costs are increasing, but at a lower rate each year. Now, looking at our variable of interest, if we consider the model on production of visits, we observe that the same number of office visits, the cost frontier of team-based units lies on average beneath the frontier for the other models that are paid with salaries. So if we look now at the effect at each decile of production, we see that this value on average is only true if the scale of production lies above the fifth decile of production. If we include quality, the estimations change a bit. So now we observe that team-based models, and in particular those which have pay performance payments, they can even on average be associated with an increase in cost, especially at small scale of production. Finally, if we look at allocative efficiency, which looks at approximation of the frontier, we see that the team-based models are associated with a smaller deviation from the frontier. This means that we can say that they are more efficient than the other models with salaries in the production of office visits. So we can expect an improvement in efficiency in these team-based models, of course, because they have more autonomy to specialize the labor in different tasks, but also to use technology in a more integrated manner. Now, the scale mix provides us interesting and counterintuitive results. So we are expecting, the traditional expectations are that the increase in the number of nurses relative to physicians will be conducive to the allocative efficiency in healthcare prices, given the difference in prices. But in this case, the more nurses and also assistants is associated with more inefficiencies. Despite counterintuitive, this result was also found before in Catalonia, and this makes us suspect that the extra nurses and assistants are not being used efficiently in these units, or that their time might be devoted to other activities such as bureaucratic tasks, training and counseling, which might not be properly captured by our quantitative production, by our measure of quantifying production. Let me wrap up everything in one slide. So this was the first study considering the efficiency in costs in the production of in the Portuguese healthcare units. We reject the hypothesis that difference in costs are not due to the factors related to the model governing the units. So this means that there are potential gains in cost containment in team-based practices with and without financial incentives when compared with other models, but this only applies if they operate at a high enough production scale. Team-based models are nevertheless associated with lower inefficiencies, and the extra number of nurses and assistants seem to be not properly used in these units. It is needed further research to detail whether there is some complementarity of supplementation relationship in the scale needs of the units. Having said that, the implications we draw from these results are that the conversion of the units from salaried workforce into team-based units should consider always the existence of economies of scale. This means that at smaller scales, practices even at team-based models might suffer from coordination difficulties, lower peer pressure, or free-riding behavior. Furthermore, in the next step, it will be interesting to go further and to identify the reasons for these cost advantages in team-based models, whether this comes from technical advantages in productions, from changing the prescribing behaviors, from improvement in reporting system and benchmarking, or even from a deeper direct involvement of professionals in the clinical governance of the units. These factors are not easily evaluated using listed data. Still, they make us think about it and they make sense in this context. Having said that, I would like to thank you very much for your attention and look forward to seeing you all very soon. Thank you.